Well, good morning. It's still morning, right? Yes. It's a great honor to be here today, and thank you for inviting me to give this talk. It's hard to follow Dave. That's the price to pay to ask to be the last on the talks. You heard him talking about zooming into the cancer and kind of talking about the microenvironment and how we can use the patient's immune system to tackle cancer. We are going to zoom out a little bit and going into the reconstruction aspect of head and neck cancer. And I thought that head and neck were the only ones who were so behind in using, immunotherapy and having any significant changes in the patient's survival outcomes in the last several decades. And Dave just mentioned the same thing about pancreatic cancer in the last 30 years. So the only thing we have going for us is our changes and our advances in reconstruction of head and neck cancer. So this is what I'm going to talk to you this morning. I have to start with a little bit about facts and myths on head and neck cancer. You all know that it is, believe it or not, among the top 10 cancers. And in the US and worldwide, there's about the sixth, and it's anywhere between fifth and sixth most common cancer. And out of those, the majority, when we hear about head and neck cancer, we're talking about squamous cell carcinomas. The overwhelming majority are squamous cell carcinomas. But there are several myths that are still circulating about head and neck cancer. And those are in the red, and we're going to kind of go over a few of those. So you've heard probably many times that head and neck cancer, squamous cell carcinoma, usually presents as a pretty painful ulceration or a mass. And I'm showing you these cases. And every single one of them, what did I do? Sorry for that, are painless head and neck squamous cell carcinomas. This big mass in the neck is painless. This white patch on the tongue is painless. And this tiny little ulcer, although it may look a little painful, is not. So they are painless lesions. Then we heard about head and neck cancer, squamous cell carcinoma, being usually easily detected in early stages. It hurts. There's a lump in the neck, it's easy to detect. Well, the problem is when there's a lump in the neck, it's already stage 3 or 4 disease. So you see these kind of presentations, and this is not a neglect necessarily. This can double and triple in size within a short period of time. The way I see head and neck cancer or squamous cell carcinoma specifically is once it's outside of the box, there's really nothing stopping it. So these are all already stage 4 cancers at the time of presentation. So the patient comes with a huge disadvantage. Then we know that definitely tobacco and alcohol contribute to the two main factors for development of head and neck cancer. They definitely contribute. There's definitely a huge role. These are two of my patients, never smokers, never drinkers. We all heard about age being a contributor to head and neck cancer. Well, she was 18 at time of presentation. And now we know a lot more, age 15, 16. So, never smokers, never drinkers. They didn't have a chance to have a pretty risky lifestyle. So, a lot of this myths still out there. We know already for a long time that infection with high-risk HPV viruses are very common in other cancers, but it's definitely associated with oropharyngeal cancer. Well, what we know in the last 10 years or so, we have a category of patients, like this gentleman here, who are HPV positive squamous cell carcinomas of the oral cavity that have no risk factors associated with these cancers. So we used to have the smokers, the drinkers. We used to have the smokers only, the drinkers only. And now we have a combination of groups. We have HPV positive smokers, HPV negative smokers, HPV positive non-smokers. And the categories go on and on and on. So it becomes extensively difficult to actually investigate a little bit more these subcategories and find what is the reason for it. So these are all presentations of squamous cell carcinoma of the oral cavity. I can tell you about 50% of those have been completely written off. Like this, very common is a condition in the mouth that's called epulis. When you have an ill-fitting denture, this patient is walking around with an ill-fitting denture for 3 or 4 months. Well, that's a cancer growing in there. Or this is my, actually 17 at the time of presentation, pregnant, 17 years old. This is a tumor of pregnancy. How many of you have heard of tumor of pregnancy? The pyogenic granulomas that are all associated with poor hygiene or estrogen during pregnancy. This is an outrageous squamous cell carcinoma, stage 4 presentation. So there are different lesions, different presentations in different patients. I like this picture because these are all the faces of the cancer today. You have males, females, young, old, smokers, non-smokers, drinkers, non-drinkers, high risk, no high risk. Who can point to whom here? You know, this is a priest. This is a lady who doesn't smoke, doesn't drink. You know, my young patient right in the middle. So they are all different faces today. So like I said, the only thing we have going for us is surgery, unfortunately, for head and neck cancer. And it is the primary treatment for squamous cell carcinoma, especially in the oral cavity. And we're talking about oral cavity separating from oropharynx, nasopharynx, because there are different modalities that work for those. The problem is that when we do surgery of the head and neck, we have major defects. And the defects of the head and neck are quite difficult to reconstruct. We're talking about 3D reconstruction. They're very complex. And post-ablation of these kinds of cancers, we have issues with restoring form and function. It's extremely difficult to reconstruct the maxillofacial skeleton. And the deformities of these patients, you all have seen them in your practice, I'm sure. The effects of the radiation, the effects of ablative surgery. This is the typical patient of head and neck cancer patient. This is still from my early career as a surgeon, not even into my fellowship training. Well, the good thing is that we don't have to have these patients anymore walking around. He can never talk. He can never swallow. He can never eat and be appropriate. This is all he has. Or something like this, where there was a reconstruction placed, keep things a little bit in some kind of a form there. But then with the radiation, with time, with scarring, this is what happens. The titanium is going to win metal over soft tissues. These people are walking around with exposed plates, with drainages, fistulas all over. Or this is a panorex, this is an X-ray of the plain film of the mandible and the maxilla. And you can see this part of the mandible this way, the other right there, and nothing in between. These patients cannot function anymore. And they have no control of their tongue either. The tongue attaches to the mandible, so there's no control of the tongue. So they are at risk for aspiration, dependent on GI feedings, dependent on trachs and things like that. Again, the good thing is that we don't have to have these patients anymore. Why? Because now we can have free tissue transfers, the free flaps that are so successful in other areas of the body. They're extremely successful in the head and neck. And flaps is one thing, it's great. I did a lot of flaps during my training, and they were all like, okay, this looks pretty good. We all can do a little bit of carpentry and try to put things together. But now, in the last 10, 15 years, we have virtual planning. We can plan things in the computer before we even touch the patient. And then we can have the results that we're looking for. We can restore both the form and the function of the patient. And we can educate the patients. We can educate our new trainees. We can actually show everybody the entire surgery, pretty much, minus the blood, without even going to the operating room. The patient's acceptance is higher. The patient understands what are we going to do with them, which is very difficult. When you say, we work with bones from other parts of the body, when you say, I'm going to take the bone from your leg and I'm going to make a new jaw, what? I can show you how, and that is actually easy to do. This is what we used to do. This is a reconstruction plate that actually can hold the pieces together. Yeah, I don't think this patient can function. There's no bite there. You can see only the front teeth touch there, barely. You can see they're like this. That's not how they were before. They cannot touch. And you can appreciate they have a huge deformity on the face because that expands outside where this would be. Now what? What can we do about this patient? Well, we can actually take everything out virtually and reconstruct them. Take a bone from the leg, the fibula. We don't necessarily need the fibula for walking or any other purposes other than stability of the ankle and the knee. And we can fashion it into a mandible. But then is this enough? I can take it and do two pieces and create this. How am I going to make the patient what we call orthognathic, where they were before, actually for things to fit? If I just go and use this, I put them exactly where they were before. Those teeth have to touch. The joint, this joint actually is out of the fossa. So this patient cannot really function very well. Now I can anticipate all the problems that I'm going to have. And actually I can see that on this side, this is what is called a sagittal split osteotomy. In order for me to be able to reconstruct this patient in the previous, and you can appreciate this is a young patient, right? They have pretty teeth. And at some point they had ortho braces on. So I need to actually do something to the other side of the jaw to move things to create the orthognathic face, I guess, the appropriate face. And I can make this is the bone from the fibula. I can make it so there is no bone inferior to the other side. There's nothing expanding. I can actually put the bones exactly where they belong into the fossa so they can have function and they don't have chronic pains and things like that. And then, why am I doing all this? Just to give them continuity of the mandible? That's one way, but they had continuity with a plate. Well, the purpose is to actually eventually having teeth so they can actually chew on. And these are implants, dental implants. You all have heard about dental implants. I can virtually plan where those dental implants have to go before even I have the bone from the fibula harvested. Actually, I can reconstruct the entire mandible while still the fibula is attached to the leg, even place the implants on, and then transfer everything into the patient's mouth. And those are highly functional. Now, it's cool to have videos because whatever I describe is not as easy. I'm going to escape from this. So this is what is happening during all this planning. Hopefully, yes. So this is a stage 4 squamous cell carcinoma of the mandible. Pretty much has taken over. You can appreciate the destruction over here. There's nothing left. The teeth are pretty much sitting on tumor. You can appreciate that. So we do a CT scan. We do a 3D reconstruction. We upload the images. And then we have this 3D representation of the patient. And we have done all the work beforehand. It's moving a little bit slow. I know where I need to do my resection, and I can be actually very generous. I don't have to worry about, how am I going to reconstruct. I need 2 centimeters. I can do 3 centimeters of resection. This is my plan osteotomy. This is the area where I'm going to cut to remove the tumor. And I will have a second osteotomy. It's a little bit slow, I think, because of the connection here. I can have the other osteotomy on the other side. I jumped a little bit. So this is the part I'm going to actually remove. And because the patient had no tissues before, it's very hard to freehand and bend any kind of reconstruction plate here with this. Then I'm going to upload the patient's own fibulas. We do angiograms to decide which bone is best, if there's any vascular disease or anything like that. The majority of the head and neck cancer patients, they do have some history of smoking, drinking perhaps, and maybe some peripheral vascular disease. And I can take this straight bone, I can virtually remove it from the leg, and I can take it into the mandible, appreciate exactly where it needs to be lined up, so I can give the patient the perfect form. Then I can plan how to create a curve from a straight bone. Like I said, we can freehand it, and with a lot of experience, you can be very accurate, but we're talking about millimeters of accuracy here. Things can be very close to millimeters. Now, it's very hard to do this on a patient who actually has been, the mandible has been completely destroyed because there are no reference points. But having the ability to recreate the mandible virtually, that actually overcomes this problem. So I know I will need the fibula in at least 3 pieces, 1 piece, 2 pieces, and another one right there. The green is the portion of the mandible that if he were to be there, this is how it should look. We don't have the mandible there as a reference. So we are recreating it visually. And these osteotomies will allow me, when I do these osteotomies and I remove that wedge of bone in between, when I close them, to recreate the contour that I need without making him in any way asymmetric. And I can align things in the remaining portion of the mandible, so I don't get the joint out of the fossa. I don't have them to have any kind of dysfunctions afterwards. And then I can anticipate any other issues that I may have perioperatively. It is very difficult to anticipate every single detail, every single problem that you may have when you're working with bones. For example, this may look that is a little bit too forward for him, but it's actually not. Once we take the measurements and when we can turn this around and see from the worm's eye view where exactly the mandible has to be in regards to the skull base and in regards to the maxilla, this is perfect. You can see the joints right there, the TMJ joints, and they're perfectly aligned. So I don't give him any kind of deformities this way. So I can do all this, and I can plan it virtually. Then I can anticipate. This is an area. What they're showing me right here is that based on the way the fibula, his fibula is a little bit curved, I need perioperatively to do a little bit of work right there. So my plate doesn't stick out and give him over-contouring that's going to defeat the purposes. So this is an area where perioperatively I have to adjust a little bit. And all that planning will come to me into details. So if there's something I don't like during the planning, I can review it. I can say, oh, this is not what I like. We have to change this. Then we will create a reconstruction plate. This is a titanium plate that will allow us to connect the pieces together. Then they will create these are cutting guides. So, okay, we plan the osteotomies, how are we going to reproduce them? Well, these are cutting guides. So when I cut this bone, the portion of the mandible will match the portion of the fibula. So when I bring everything in, all I have to do is just put the plates and the screws, and the mandible is completely reconstructed. So this can be done for the maxilla. This can be done for the mandible. But what else can we do for these patients? Not everybody can have a fibula. That, let's say they had an accident, they had other issues, or the defect is kind of small and maybe not necessarily require this type of reconstruction. We can do the same thing on the upper jaw as well, and those are beautiful reconstructions because the maxilla is a lot more complicated than the mandible in regards to where you're going to actually connect the bones. This is a stage 4 cancer of the maxilla, and unfortunately we cannot send the cells to kill this cancer. We actually have to remove it. But what's going to happen to this patient? Imagine if you just take the middle face out of somebody, right? The whole thing is going to collapse. Not only collapse, this patient will have issues with every time they eat or drink something, everything will come out of their noses. They will never be in public. And what do they have to do? Well, they have to wear this obturator, which is a big, heavy denture that will actually plug the hole and keep their face into some kind of position. But those are very difficult to maintain, and that's the traditional way, still happening. So unfortunately, this is the way we still do surgery. Same way, same thing. We remove the tumor, and then what you see up here is these are the sinuses. This used to be the nasal cavity, no more. So this is the tumor, and this is her. She's wearing this heavy denture. This is a heavy piece of denture that is just plugging the hole. You can appreciate she's trying to hold it there. She has some kind of form, but definitely no function. She cannot chew with that because it just falls down. It's so heavy, it just continuously falls down. And then when she takes it out, that's all she has. She has these holes, the oral and nasal communication, the communication with the sinus, so she cannot really eat or drink without it, just because things will come out of her nose. And she's pretty much stuck with that. Well, the defect is relatively small to go ahead and do a fibula flap. It will be kind of an overkill. So what else can we do? Well, we can use special implants. Those are called zygoma implants. These are specific titanium implants that, since we don't have any bone anywhere, the implants usually, the dental implants have to go into good bone. Well, there's no bone there. So we can engage the zygomas. The zygomas are really good bone. Engage the zygomas and reconstruct a denture. The prosthodontist will reconstruct a denture that will actually allow the patient to have a permanent prosthesis that does not have to be removed, that she can function on, chew, and it will be extremely stable. So these, again, are virtual implant and guided. This is what you see here, the guided portion of the surgery, because this shows where there's no bone. All you see is the maxillary sinuses, and up here we have the zygoma. So we can engage the zygoma. These are about 60 to 70 millimeters long, so they need to be guided, and we can do that with just traditional guides where you just thread the implant in, or we can do it with navigation, actually. We can have real-time surgery. We can see the implant going into the zygoma and engaging, and actually this is the way to do it nowadays because very easily you can get into the orbit. It's very easy, instead of actually threading the implant right in this location to get, this is the orbit, to actually get into the orbit and have some issues, or coming out of the face, because again, you have an area right there that is absolutely nothing, just air. This is the sinus, so you have to go through empty space to engage the zygoma up here. So we do this nowadays with navigation, what we call perioperative navigation, where we actually, similar to robotic surgery, we don't look to the patient necessarily. We're working on the patient, but we're looking at the screen and ensuring that everything goes in the appropriate way. And we have guides and visual and audio warnings if we get close to structures like a nerve or the orbit or in air. So this is the way we do it nowadays. So we place the zygoma implants, and this is the planning. Again, you can explain to the patient, when you tell somebody, I'm going to put implants up here on your cheekbone, that's not very easy to understand either. So, and how are those going to be used by the prosthodontist to reconstruct? So this is the planning for her. And this is her just 10 days after surgery, after placement of the zygomas. They are really minimally invasive surgeries. She doesn't wear a prosthesis for the moment. And this is her with an actual prosthesis that will click onto those zygoma implants, and she doesn't have to hold it there and talk like this or hold it with her tongue because it's too heavy and falls down. So our prosthodontist does wonderful work by recreating, a good occlusion and stability and function and things like that. So, again, these are the oral cancer patients of the millennium. These are the patients that we face and see every day. This is where they can start. And so we hope that the new face of the patients of the millennium will not represent what we used to have in the past. The defects, the anti-gum deformities, the inability to eat, the inability to drink, the PEG dependency or the trach dependency. These are the new faces, and we hope that when we give them these new faces, they don't have to wear the scars of the cancer patient. Thank you. So they used to do the mesh to recreate mandibles, and it wasn't titanium at the time; it was other kind of alloys. And the problem with that is that they were very hostile to the tissues, so you have exposed bone into the oral cavity or through the face, as you very well saw. And the other traditional way to do is to actually use acrylic and just really plug a hole. So it was some kind of a mesh that was a combination of alloys. Yeah.
Is the oral cavity bacteria exposed to these things and osteomyelitis?
So that's an excellent question. So there used to be a lot. First of all, the free tissue transfer. The tissues are bringing their own blood supply, so they are less dependent on healing processes other than just healing of the osteotomy. So the environment of the oral cavity is definitely non-sterile, but we know nowadays that we can graft the oral cavity without high risk of infectious and osteomyelitis because the actual bacteria inoculum is not significant enough to have that, unless you have a set of infection, like an infection already present.
Do you have a sense of how many of these tumors are HPV positive?
So now, none of us can probably answer that question for the oral cavity specifically. It's actually in the less than 5 years that we have this new category of HPV positive, negative, everything else, patients with oral cavity cancers. And we used to think that HPV positive cancers are better cancers because they were treated easier with radiation, chemotherapy, they were responded to treatment. For the oral cavity, that's not the case anymore. So we cannot really even de-escalate radiation or chemotherapy. We still want to treat them in the same way because we know that we have failures.
I see people for addictions, and I'm told by the head and neck cancer surgeons that often this surgery is successful, but doesn't work out because the addiction isn't treated. I'm having difficulty trying to collaborate with surgeons to work with those patients. I wonder if you've had any experiences with working out collaborative relationships with the addiction specialists.
So a lot of these patients, they require heavy pain medications and they are chronically exposed. But with this new way of approaching them, the surgical time is, the healing time is less. The effects of the surgery are significantly less. So my experience is that I have less and less issues with addiction with these kinds of reconstructions that I inherited early on into my career. So, and I think that early on, the more pain the patient has from the actual cancer, the more difficult it is to control them afterwards. So, we collaborate very early with these patients, but with the new reconstruction, I hope at least that will be, decreased with time.
I was thinking less of the opioids and more of the alcohol and tobacco.
Right. So the unfortunate part with the tobacco and the alcohol is that it is a very difficult mindset for the head and neck cancer patient to change. Now, our Wilmore Cancer Center, our head and neck service line, every patient sees, the alcohol and smoking cessation team right away, and they have extreme support. So when it comes to multidisciplinary approach, if they are addressed early on, and they keep on their support groups, they have better chances of, being better controlled. But that remains a problem. Yes.
Are the head and neck ENT and plastic surgery residents incorporated into your program?
So I'm a maxillofacial surgeon. I work with plastic surgery a lot, and our residents work together. It just happens in here that the ENT service have, they are their own team, but everywhere else I work, all three work together. And that's great for the resident training, as you point out, because the resident can see the multidisciplinary approach to patients from the reconstruction point of view, and yes, so everywhere we work together.
You also want to tell them about the program we're starting.
Oh, okay, the double degree? Can I? All right, great. So that's great news. So we are at the moment. I've been here for 2 years actually. In about 2 days, I'll be the chairman for 2 years, and with Dr. Topman's support, we are going to be starting our 6-year program. Maxillofacial surgery traditionally has 2 tracks. One is 4 years certificate program after dental school, and another one combined certificate and an MD program. So we know that the combination of an MD, being able to obtain your MD, obviously the training is superior, the advantages in the future, the ability to go into fellowship training, join academia, do more research, significantly changes. So we're going to be introducing the second track for a third resident that we're going to be admitting to the program. So one of our residents will be doing medical school parallel to the ROMFS training. So that's outstanding. About 2/3 of the programs in the country are that way. They do offer an MD degree, so including Buffalo and several other programs in New York. So yeah, that's what we're doing. So that is exciting news.
Certainly, has there been any concern about potential differences in density between the actual fibular bone itself versus the maxillofacial bone in terms of compact and size?
Excellent question. We know the fibula is just cortical bone with a narrow space, and the maxilla and the mandible. The maxilla is more porous, and the mandible is different. For the purposes of the reconstruction, actually, the benefit of the fibula is that it's cortical bone, and the healing process it's seamless, pretty much. Thank you so much. Thank you. Thank you.